This topic is disseminated intravascular coagulation. Disseminated intravascular coagulation, or DIC, is a life-threatening disorder that occurs when there's widespread activation of the coagulation cascade. In DIC, clotting factors and platelets are quickly consumed. This causes abnormal clot formation, which is then followed by hemorrhage. DIC has many risk factors and causes. One of the first is trauma. DIC can especially occur after major trauma to the body, such as in a motor vehicle collision. When major trauma occurs, the body is going to send clotting factors and platelets to various sites in the body to try to close up wounds. If there are too many of these sites or too many platelets or clotting factors are needed, they're going to be used up and there's not going to be any left for the rest of the body. With sepsis, infection becomes widespread across the entire body. The body recognizes bacteria or viruses as toxins and is going to try to get rid of them. The stress on the body from the infection can cause abnormal clotting and eventually result in DIC. Various obstetric conditions can also cause DIC. In the case of placental abruption, the placenta becomes detached from the uterus wall. This results in hemorrhage. Again, just like with trauma, the body is going to send clotting factors to the site to try to stop the bleeding, and they're all going to be used up and leave none for the rest of the body. In preeclampsia, increased blood pressure is going to put a strain on the vessels. Strained vessels are more prone to damage, and if they are damaged, they're going to need those clotting factors to heal themselves. Finally, if a fetus dies while in utero, the body is going to recognize it as a foreign substance. Just like with toxins or bacteria and sepsis, the body's going to try to get rid of it, and there's going to be clotting factors at the site. In the case of malignancies, such as certain cancers or leukemias, procoagulation factors are going to be released. These procoagulation factors are essentially going to summon the clotting factors to the area, and just like with all the other conditions, use them all up and leave none for the rest of the body. Before we ever see external manifestations of DIC, there are going to be internal manifestations. Remember that clotting factors are being used up rapidly, and microthrombi are going to be forming in the vessels. These microthrombi are going to obstruct blood flow to places like the kidneys. Clients may have a decreased urine output or an increased BUN and creatinine as an early sign of DIC. They may also have blood in the urine as clotting factors dissipate. Once the clotting factors have been used up and clients are beginning to bleed uncontrollably, you may see bleeding from the gums or the IV sites. You could also see it coming from the nose. As you can see in the image here, petechiae occurs. Petechiae is simply just little spots of bleeding under the skin. Ecchymosis or bruising can also occur. Let's talk a little bit about laboratory findings with DIC because I think these can be really helpful in understanding what is going on. First off, we're going to have some things that are decreased. Like I said in DIC, our platelets and coagulation factors are going to be used up. So our platelet count is going to decrease and our fibrinogen level is also going to decrease. Think of fibrinogen like the mesh that keeps clots together. It's all going to be used up, so the level will go down. So once all these clotting factors are used up, the blood is pretty thin and our clotting times are going to be really long. We're going to see an increase in the PT and INR, as well as the activated or APTT. Finally, as microthrombi begin to break up, D-dimer is released. If we have a lot of microthrombi starting to break up, our D-dimer levels are going to increase. Treatment measures and interventions for DIC are going to be supportive. It's really important that we treat the underlying cause first. So if a client has an infection, we need to make sure we're administering antibiotics on time. If a client has multiple wounds, we need to make sure that proper wound care is happening. We also need to frequently assess the client for bleeding. We can look for bleeding in the urine, such as with hematuria, or at the IV sites. Clients should have frequent laboratory monitoring of their blood, especially our coagulation labs, such as our platelet count, our PT, and our PTT. We know in DIC, all of the coagulation factors are used up, so we need to replace those. We need to replace clotting factors, as well as fresh frozen plasma and platelets. If clients are hemorrhaging and bleeding through different sites on the body, we may need to replace blood cells, such as with packed red blood cells. Clients with DIC are going to have less circulating volume, and this means less oxygen getting to the organs and tissues, so we may need to supplement oxygen for these clients. Finally, like I mentioned earlier, the kidneys can take a hit in DIC because of microthrombi inhibiting perfusion. We need to carefully monitor the intake and output for clients in DIC to ensure that kidney injury is not worsening.